Welcome back, everyone, to Einstein's Eyes, our YouTube channel where we talk ophthalmology, medicine, innovation, tech, healthcare policy, and the like. Today, we're going to explore the world of hydroxychloroquine, or Plaquenil. This drug has been around and used for decades in the treatment of various conditions, including lupus, which can give you that butterfly rash on your face. It can affect your kidneys, something called lupus nephritis, rheumatoid arthritis, which affects the joints in your hands and feet, Sjogren's syndrome. So it can mitigate Sjogren's syndrome, which is a disease that Jon and I see because it causes dry eye and dry mouth, but mostly the dry eye part is in the ophthalmology realm. Hydroxychloroquine is a really interesting drug. It's an anti-inflammatory drug that has a complex pharmacology. We're not going to go into that. It basically dials down the immune response, so the inflammation is reduced. There was a controversy back when COVID-19 was running rampant. Even on the Joe Rogan podcast, they talked about it. It was the horse pill. In ophthalmology and in medicine, we know better than to call it that. I'm not going to dive into the COVID controversy because that's in our past and good riddance to it, but it is a legitimate drug. It's also used for malaria, been around since, and first introduced since the 1950s, primarily for malaria. For today's talk, we're going to describe Plaquenil for your eyes, how it can affect your eyes and the complications, which is this term called Plaquenil retinopathy or hydroxychloroquine retinopathy. So here's a nice diagram and a nice image of some of the aspects of hydroxychloroquine and what it can do. Here is an image of Plaquenil retinopathy or hydroxychloroquine retinopathy. And this is what we look for. In particular, we are concerned about patients being on this drug for 5 years or more, being on the drug over a dosage of 400 milligrams, increasing age over 60, kidney and liver disease, and the cumulative dose.
Hi, I'm Jon Ditkoff. I'm a general ophthalmologist specializing in cornea, and I'm in northern New Jersey. I've been there for over 30 years. I originally trained at Albert Einstein, where I did my residency and did my fellowship up in Albany doing cornea. At Albert Einstein, I met Carl, and we worked very close together, and that's how we developed this relationship, and that's how we named the site Einstein's Eyes. So, Carl, do you want me to talk a little bit, or you want to?
Yeah. So we're doing a little backwards, but I'll just say, yeah, Carl Rosen. So I'm in Anchorage, Alaska. I do oculoplastics and neuro-ophthalmology at Ophthalmic Associates. Been doing this for 30 years. So Jon and I were devoted residents back at Einstein.
I loved your overview. I'll just hit upon some things. So number one, I always really was interested about COVID. I know we're not going to labor on it, but during COVID, as we all know, there was some press, and I'm not going to go into that. But one thing I will tell you, since that time, there have been studies that came out, and they're not all consistent. So, it's not that important, but there is some school of thought, there's no question. They compared groups of people that had lupus and sarcoidosis. They took those two groups that were being treated with Plaquenil, more lupus, I think. And they saw retrospectively when they did studies that the people that were on medication like Plaquenil for at least a year prior to getting COVID were less likely to have an exuberant inflammatory response than the people that weren't on it. Now, that doesn't mean if you took COVID and you listened to the president, you were going to be safe. But I'm just pointing out that, and it does make sense. This is a medication that's a wonderful immune modulator. It decreases the immune response. It decreases inflammation. So it makes some intuitive sense that if you're someone who develops a disease like COVID, then the big risk with COVID was the inflammatory response and the immune response to the virus. It does make sense to some degree that it might protect some people, just like giving people steroids, which is one of the treatments we gave people when they had a significant immune response. Now, going on to the other stuff. So I take care of many people that are on hydroxychloroquine, Plaquenil, and Carl hit upon the most common reasons. There probably are some other autoimmune diseases. I've seen some people with alopecia where it's been tried. Again, this is not my specialty. So all I'll say is that rheumatologists, immunologists are using it for many different diseases that are immune related, and it suppresses the immune system. I think Carl also hit upon the risk factors, but I will say the majority, the overwhelming majority that take Plaquenil, it is a very safe medication for in terms of the eyes. As an ophthalmologist, I get consulted on it regularly, and I warn patients about the risks because I think it's important, but it's extremely rare. I mean, in over 30 years of taking care of patients, I've had 3 patients develop ocular toxicity. One of them, unfortunately, lost vision that was not reversible. The other 2, we caught it early enough that we caught it. But a couple of key things. Carl mentioned what we look for, which is this bullseye maculopathy. But to be blunt, that's really late. What we do is we look, I screen my patients twice a year starting day 1. Now, that might be overkill. I mean, recent studies have said, unless you're in one of the high risk groups that Carl mentioned, over 60 years of age, you've had significant weight loss, you're on a very high dose, liver, renal issues. That's what people are saying now. But I guess I grew up with this medication, and I learned from the people that taught me, and I still see people twice a year, even in the early years. I don't think it's a bad idea. I educate them whenever I see them. I do certain tests. So what do? I do a visual field 10-2 test, which we don't have to go into, but it's a visual field test that's meant to catch an early visual field defect, like what we call a paracentral scotoma, that might be seen early when someone has a retina problem. I do a Farnsworth test, which is a special color vision test. And that also, one of the earliest signs of Plaquenil toxicity is loss of color vision. So I tell my patients, listen, if you just feel like things don't look quite as brilliant and red, look a little more washed out, I'm doing Farnsworth tests on at least about once a year, maybe once every 2 years, but I have a baseline. So by doing that, if they even start to lose a little bit of color and every other test I do looks good, that might be enough for me to warn them and stop the medication. I do macular OCT testing, which has a certain characteristic appearance early on. So that's even before the bullseye. There are retina doctors that will sometimes do ERGs. I've never done that. And then, like Carl said, photographs are great because it might catch a little bit of pigment or a little bit of a change in the retina. But having said that, if we catch it early and we stop the medication, that person is going to be fine. But once the disease starts to affect vision, unfortunately for many people, it's irreversible. And that's why it's so important. Anyone out there that's taking this medication regularly, you should be seen by an ophthalmologist for these testing. And then the last thing, like Carl mentioned, is cumulative dose. So I tell all my patients, if you're on it for a short while, the odds that it's going to cause a problem, very unlikely, especially if you're on a low dose. But if you stay on 400 milligrams a day for more than 5 years, that's when it becomes a little more risky. I have patients that have been on it for 15 years, and I tell them, I always will say to them, listen, you're doing great. It's working for you. Your rheumatologist and you are happy. But whenever you see your rheumatologist, you should have a conversation and say, hey, should we consider a different medication for me? Or should we consider lowering my dose? Because unless I bring that up, everything's hunky-dory. No one talks about it or thinks about it. But it's good to be proactive about trying to lower your dose periodically. You might not need such a high dose for so long. Right,
the other thing that's interesting is that it happens so slowly that folks don't really get a sense that their vision is changing or that it's getting worse.
Excellent
That's why
point.
it takes somebody like us to look in with a biomicroscopy and actually see the bullseye maculopathy, or that round pale area in the center of the retina. It's called the macula. So that's why there's value to seeing somebody like us to help out and intervene before it gets to be a stage where you're really in trouble.
Yeah, that one patient I had, I'll never forget her. She had significant visual loss, but she was being told by a rheumatologist to see an ophthalmologist for a couple of years. And then finally, the rheumatologist said, listen, I'm going to stop the medication unless I get a letter. Thank God the rheumatologist did that. And then she came in and we caught it. I mean, we caught it too late, but at least she hadn't gone blind and she had some visual loss.
Right.
It could have been a lot worse if she waited.
Hydroxychloroquine is a great drug. It's been a valuable tool in treating autoimmune diseases, as I mentioned, lupus, Sjogren's, rheumatoid arthritis, and these happen a fair amount. So it's a really important drug in the armamentarium, but it's not without risks. And the retinal issue is a serious issue. It comes on, it creeps up on you, it sort of sneaks up. And that's why you want to see an ophthalmologist, somebody like us, who can, help determine if there is toxicity or if there is a problem. Hey, thanks folks for joining us at Einstein's Eyes. Please share, subscribe, hit the bell, and we are looking forward to seeing you on the next episode. Jon, great seeing you. Thanks a million.
Great seeing you.